My name's Laurence Taggart. I'm a learning disability nurse and I'm a psychologist. Um, Obviously, I'm using the word learning disability because it's what we use within the UK, but sometimes I interject with intellectual disability. It depends where my head is. So the last 29 years, it makes me sound too old. I've worked at Ulster University in Belfast in Northern Ireland. And for the last number of years in that post, I held a professor of intellectual disability research, which I thoroughly enjoyed. In the last 10 years, we've been looking at developing interventions for adults with intellectual disability and children and doing randomized controlled trials. So I've quite an interest in this area and how do we do that, and I'll share some of that. Um, and then on the 1st of January this year, I took up a new post in Queen's University Belfast, the total distance of 2.5 miles away, and I became a professor of implementation science. So some of this talk is going to go into the world of implementation science because I think it's really, really interesting how trials and implementation science all blend into one. So listen, I'm going to just talk a wee bit about some published papers that we know that exist, and then, as Yona said, going to focus specifically around the study around diabetes called My Diabetes and Me. But here we go. Okay, look, you probably know this, but there's been a number of research articles published in the last number of years looking at how do we engage adults with intellectual disability in randomized controlled trials. And there's been several papers been published recently, well, the last 20 years, saying that about 90% of randomized controlled trials exclude people with intellectual disability. There was a recent study done by Paul et al. Within the UK looking at the National Institute for Health Research, and they found that intentionally 60% of research studies excluded people with intellectual disability, basically asking, can you consent or can you read or write, or those sorts of areas. And then there was other studies now starting to look at unintentionally. So they're not really thinking about how they make reasonable adjustments in that research process. And the other big difficulty, that's researchers doing this, making this harder for people with intellectual disability to engage in trials. But the other big problem that we have is gatekeepers. And as you know, a lot of people with learning disability are surrounded by family, by paid staff and health and care social professionals, and they have their perceptions of whether people with intellectual disability could engage in a randomized controlled trial, can make a decision for themselves, can consent, would be able to go to an intervention. And that was always in the back of our mind. So the issues around trials itself, the methodology, and the issues around gatekeepers as well as some of the limitations that people with intellectual disability present in relation to communication and ability and consent, they do make it harder to recruit. There are greater hurdles we have to overcome to sort of make sure that we address consent. Again, how do we ensure people with disabilities can understand randomization? What's the fidelity to an intervention? And then how do researchers make reasonable adjustments? This is some of the challenges that we have. And again, one of the biggest barrier to getting a large funded study is under recruitment. And I think studies in the past, and many studies in the past who involve people with cognitive disabilities, such as those with intellectual disability, they don't recruit. They fail to recruit. And that's not good from a funder perspective because funders then won't fund you. The research and studies may be longer as well, and then that takes more money as well. So we had a PhD student called Peter Mulhall a number of years ago, and he decided to do a PhD in the ethical and methodological barriers to including this population within trials. And it is a lot more complex than we think. So I'm just going to share some of Peter's work. There was 3 studies. One was a systematic review, and he looked at 52 randomized controlled trials. Some of them were psychopharmacological, some were psychosocial. And he looked at these papers and he was asking, what are the barriers from a methodological perspective and what were the barriers from an ethical perspective in relation to engaging people in trials. And then he undertook some of the people who wrote those papers, and I don't know, if you were one of the people, I don't know, but some of the people may be on the call today. He interviewed some of those people, some of those leading randomized controlled people around the world, to sort of go into deeper of those methodological and ethical challenges. And then he undertook a Delphi study, again, to try and look at, can we come to some sort of, what would be the consensus, what would be the items that we would need to do to develop some form of checklist. So this is the normal stages. This paper was published in Social Sciences and Medicine in 2018. And this would be your normal stages and challenges that you would have to go through to recruit anybody to a trial. So the whole issues of randomization, representativeness, and then control, and then some of the issues around trial, and you'll all know that as well. And again, if we look at the ethic process, it's not just as simple asking somebody, do you want to consent? I can say yes or no, but we have different stakeholders to go through and different perceptions. And again, they pose a lot of ethical challenges before we get to a person with intellectual disability. So this is Peter's PhD, trying to summarize 3 years, 3 years of a PhD in a couple of slides. So the first one was around participants' factors. So the issues to do with the person with intellectual disability in relation to their comorbidity and their level of disability. And they focused around the heterogeneity or the different learning styles. They focused around, can this population complete self-report measures, and does the psychometric properties hold for this population? Again, research is abstract. So how can we as researchers explain research, randomized controlled trials in a more coherent way? And again, there's these maternalistic attitudes from family carers and paid staff that, maybe research can do more harm. Maybe people don't have the capacity to understand that they may be overprotective of this population. And again, this could restrict how we engage. Other issues in relation to the design of the study itself. If you're looking at recruitment, now in our diabetes study, we had a very short window of 3 months. And looking back, that's just mad. To recruit people with learning disability, it takes a lot of time. And for some of the reasons we'll talk about shortly. Again, ethics bodies are looking at burdening participants. So again, how can we reduce the burden, particularly if you've got a number of questionnaires? And again, how can we assess for capacity, and how can we ensure that we've got informed consent as well? And then the last one was around systems. And again, these are to do with the gatekeepers and the multitude of gatekeepers and their maybe biased attitudes. Also, maybe their lack of understanding of what a randomized controlled trial is. So, as you know from ethics, we're not allowed to approach a person with an intellectual disability. So we're now dependent upon a frontline member of staff who may have limited understanding of RCTs, and they have to try and sell that on our behalf. And again, commitment, trying to get commitment from really busy staff. Staff may not have the capability or the capacity, but also many staff who really work in a broken system and really struggle to do the day-to-day job. And then you add on, could we support in a randomized control trial? And again, this adds time and it adds additional funding. So very similar study was done in America to the one that was done in the UK. This was an American study looking at clinical trials, and again they found most clinical trials either intentionally or unintentionally exclude adults with an intellectual disability, again for the exact same reasons around capacity, consent, making reasonable adjustments. And what they also found was that staff actually had a decision. Well, some studies actually asked staff, could you give us consent to whether a person with learning disability could engage in the study? So really strange scenarios, but they really are affecting the numbers of people we get for trials, and the difficulty we then have. If we don't have enough people engaging in a trial, then we won't know if the results are significant. So I'm assuming Everybody's still alive and alert, and there's no magic questions jumping up in the chat room yet?
This is amazing. We're all wide awake. And
You're great. Great time in between you and your lunch. Okay, so I'm going to talk about our NIHR, which is the National Institute for Health Research, and this is the health technology assessment one, I think it is. It's a full trial. It's £2.1 million, and we were to identify that's a mistake. It's 2.1 million. We were to identify 450 adults with an intellectual disability, and half of them would be randomized to the Desmond ID, which is a structured 9-week education program, and it was taking part in Northern Ireland, England, and Scotland. So we had an internal pilot where we were to recruit 108 people, and then we had certain progression criterion. And when we met the 108, and if we met the progression criterion, we would smoothly move forward to the full trial. We had one site in Northern Ireland, one in England, and one in Scotland. And we were using a methodology called Quintet. I'm not sure if anybody's heard it. It's called the Quintet Intervention Recruitment. And we got an extra £111,000 to do a SWOT. So this was a study within a trial. So what we wanted to do was, we knew from the research, we knew from my PhD students' work, that clinical staff struggle to identify adults with intellectual disability. And that sometimes results in studies not getting funded or not meeting their target. And that's a real big problem, as you know. There was challenges in relation to attitudes and perceptions that people, professional staff, family carers, paid carers, maybe clinical research nurses hold towards the utility of conducting trials for this population. And we also wanted to explore the enablers and the barriers to how clinical staff identified adults with learning disability and type 2 diabetes. And we wanted to understand that those challenges in this internal pilot study before we move to the main trial. So normally what you do is, at the end of a trial, is a process evaluation. But the problem with the process evaluation is that the study is done and dusted, and then you retrospectively, where this study actually took place during the internal pilot on a day-to-day basis. So the methodology was QRI, Quintet Recruitment Intervention, different methodologies, focus groups, one-to-one interviews, documentation review. We wanted to identify the barriers and enablers in identifying adults with intellectual disability and type 2 diabetes. We interviewed different gatekeepers, GPs, practice nurses, clinical research staff, the study co-investigators. I was interviewed, as was the co-investigators in Scotland and England. We interviewed the recruiters, which was actually the learning disability nurses. We actually interviewed people with learning disabilities, and we reviewed the documentation. So there's a lot of information going on, and we had weekly or 2-weekly meetings as well. And all this we analysed. So this is what we did. This is hopefully this is clear, but we were trying to understand the recruitment obstacles from the people on the ground. So we were trying to map the different pathways and the eligibility procedures. Like you're saying, we interviewed trial staff and some patients, audio recordings of we actually audio recorded how the clinical research nurses were consenting the participants. We were also audio recording how some of the nurses were speaking to the people with learning disabilities about the study. We wanted to know how well were they selling our study. Now, we weren't focused on the people with learning disability. We were more focused around that process for how the gatekeepers, the clinical research nurses, the learning nurses were speaking to the adults with learning disabilities about our study. And we took audio recordings of that. And then again, we had documentary analysis to check. So out of that then, as the weeks went on, it was a 4-month recruitment period. We collected all our data and we met every couple of weeks. And very quickly, before we started the study, we had a user-friendly PSI, we had a video, but what we realized was we needed more information for staff. So we've actually created a new video with people with learning disabilities to actually sell the education program to the staff, to try and educate them around what a randomized controlled trial was and the benefits for this population. We needed tips and cue cards, again, for the clinical research nurses, for the frontline nurses, to try and, again, all of them be very articulate in what they say to sell this project, because some of them are going off script, some of them are just saying things that were incorrect as well. We also needed to have workshops and for the clinical research nurses. We had like a clinical nurse monthly meeting just for them to talk among themselves, to identify barriers, but also to look at some of the solutions and enablers to how they were making reasonable adjustments. Like, for example, one of the things we had to do was weigh people. But if a person was obese and was in a wheelchair and we only had scales for the person to stand on, then what did they do, or how did they get information? Or if a person refused to give blood, how could they manage getting that blood, maybe contacting the GP? So we looked at different changes to the trial literature and at different adjustments to the trial pathways and processes. And you could just imagine, as those changes were taking place, we had to do minor ethical amendments, and we had to do different protocol. I think we're on protocol version 18 now. And all this was to help recruitment in the main study. So here's just some of this is how it worked. This is very complicated, but this is what was going on. So here we tried to work with GPs, but basically GPs didn't, like, I think out of 72 GP practices, a lot of money went in to going around to every single GP practice. We only recruited 4 people. So that process of working with GPs failed. Then we looked at our nurses on the teams, and we asked them to develop a screening log. So basically, if I went to one nurse, I was doing some of the data collecting as well, and we went to one nurse and we said, how many people, meets the inclusion criterion? She said 10. I said, happy days, great. And then I said, how many information packs did you send out? And she said 4. I was like, 4, but that's a loss of 60% people. So I said, why did you not send it out to those other 6 people? And she said, well, one of the ladies, she's too old. And I said, what age? And she said 63. We don't have an upper age limit. Another man, she said, oh, he's too grumpy. Grumpy is not an exclusion criterion. Another woman, she lived with her mum and dad, and she said, oh, mum and dad don't have transport. And I said, but sure, we're going to pay for taxis. And then another lady, she said, I just don't think she would take part. So the professional staff had biases, and that was losing us potential participants as well. And again, some of the voluntary organizations who we contacted, some of the charitable, like the residential homes or day centers, we spoke to the managers, and some of them were saying, we don't even know if they've got diabetes, which is frightening, when you think about people developing hypo or hypers. So that was the sort of information. I'm not going to bore you. There's a paper that's just been published the other day that I will forward. That's the sort of information we were collecting. We were looking at these screening logs as well. And we interviewed people with learning disabilities. And when we got the people with learning disabilities, like, so many of them, all of them could recall the whole process around it. But our problem was not the people with learning disability. In this study, what we found was the problem was the gatekeepers and the research nurses. They were the biggest challenge for us. Because we couldn't get through we couldn't get through those processes, or we had difficulties, then it was difficult to speak to a person with learning disabilities. So 3 big themes that came out. The first was the mixed opinions on empowering people with intellectual disability and the value of the study. We also interviewed some of the site senior people one very senior person said, they're all from a learning disability background, said, we don't believe people with learning disabilities can do randomized controlled trials, so why would we get involved in this study? But even though we'd given £500,000 to that site to recruit 180 people, and if the senior manager's saying that, and we were only looking for 36 people in this internal pilot, and we got 7 people. And that was a city of 4,000 people with learning disabilities. Likewise, some of the teams said, these are learning disability teams, said, diabetes isn't a priority for us. Or they might say, we have nobody with type 2 diabetes. That contradicts the systematic reviews. Also, there was a real reluctance related to putting potential participants forward, probably more to do with the bias as well that the staff had. And then it was that whole emotional labor of, when you actually identify a person with learning disability, which took a long time, more than we ever expected, you have to send a letter out. Well, most people with learning disabilities don't respond to a letter. So then we weren't allowed to because of ethics. And don't forget, the participant information sheet was 14 pages, because that's what we had to do by ethics. We caught on, and we actually had a 2-page summary after that. But we had to ask somebody in this voluntary sector, or one of the nurses, could you then ring the person with learning disability? And whenever they did that, 50% went on the consent. But that process was a long time, or there was multiple phone calls. And that was even before one of my research team went out to consent the person, and then to do the baseline observations and data collection. So very quickly, this study just tells us about the importance of systems and processes. And I would really encourage people now going forward, when they're doing trials, to develop a screening log, and that's called SEER. And that's really to help people on the ground to identify how many people meets the inclusion criterion, how many packs that they've sent out, and then for research staff, very gently, and it is gently, to try and ask the person, the person who's sending the packs out, to rethink about why you're excluding some people, whether it's because of hunches you have that they're too grumpy, or they wouldn't take part, or they're too old, to look at that inclusion criterion. The other problem we had was collaboration agreements, because we had multiple sites with multiple partners. Some people wouldn't release staff until those were signed, but we'd already started the timeline for baseline data collection, and that held a lot of staff back. Again, making sure your staff are recruited and trained way before the study started. Again, because of the collaboration agreement, some sites wouldn't allow their staff to be trained in trials and on the delegation log. That just held stuff up. And again, we had an amazing trials manager. And I wish we only had it in Northern Ireland for the whole study, but I wish we had trials manager at every site. But she was on other trials. But, it's just thinking about the role of the trials manager. And again, that linking with teams. And as you're saying, during that internal pilot stage, it's really important to have that regular feedback every week or every 2 weeks around what's happening from the people on the ground at each stage. Learning from that, and then trying to respond and think of solutions. Again, working with your PPI team, because like you're saying, we had a 14-page PIS that was all user-friendly and ethically approved. But we realized that was a turn-off. It would be a turn-off for me for a trial. So we had to reduce that to 2-page, and that had to go to ethics and all that, and go to your PPI partners. So it's just thinking through, trying to, instead of just jumping in, which we did, jumping in and saying, we're going to do this trial, this is a brilliant trial. It doesn't happen like that. So again, you need to think of the numbers needed for recruitment. We were working on 40% over recruitment. Some of our sites were on 80%. Like we had one site was 179 people identified who met the inclusion criterion, but for all sorts of reasons, we only ended up with 29 people consented. Again, really engage early with your learning disability teams. And I mean, go out, and since COVID, everything's been in teams, go out, meet them, bring Marks and Spencer's buns and coffee. GP practices, we've struggled with. I wouldn't engage with GP practices at all. too much effort for little return. And again, identify training issues well before your study starts to make sure staff have their confidence. And again, make sure that you're on top because you've multiple sites. Every site have different systems and different processes. And if you're only going to sites a couple of months beforehand, it's very difficult to get their systems on board on time, to get that collaboration, the system signed, and then people to be got in post quickly. Because that was one of the biggest areas of our study. So, going to take you back and think of the My Diabetes and Me study in a different way. This is retrospectively. So in this study, the period for the whole study. So we actually only recruited out of the 3 sites that we had, one in Scotland, Northern Ireland, and England. We only recruited about 53 people out of 108. So we knew we were never gonna, we were in the red. So we had to bring another site on, and we did, and they got us 29. So I think overall we got 75 people in the internal pilot. We needed 108, but we had circumstances with this QRI study with lots of learnings, and we had procedures to go forward. We got the funding to go forward to the full trial. And now we've finished the trial. We finished the trial in October last year, and we only recruited 265 people out of 450. So from a statistical point of view, we're never going to know what it works. But any trial, even if it doesn't work, there's always learnings from it. So I sat down with my staff to say, what were some of the problems? What were some of the problems of getting people with learning disabilities in an education program and running it? And just to say, by the way, we've applied for a costed extension of £250,000 to recruit another 100 people to try and bring it up to 350. So we're just waiting to hear from the funder any day now whether we've got that. I think things are moving progressively. So my question to the research staff, how hard is this? Like, why was it so difficult? So we talked about it. And one of the things that we got into was complexity. How complex is it to take a person with learning disabilities, try and say, would you like to go to an education program? And this is, we did a systems map. I know it's very busy, and a lot of people say you shouldn't show that, but it just shows you the complexity. So there's the person with intellectual disability. And they're very much, if you look at it from a combi perspective, do they have the capability, opportunity, motivation? But they live with family carers who also have their capability, opportunity, motivation. They live with paid carers who also have capability, opportunity, motivation. But there's also this organizational issues going on. Do they have buy-in from senior management? Some of the stuff that Rosie found in her quintet study. What about organizational readiness, staff capacity and capability, staff training? So that was just us trying to think about complexity. And then that started to look at, well, what were some of the other challenges? And we're now moving into using implementation science. We're going to be using like CIFR here in a second. So using Rosie's paper and other documents we've learned from the big trial. Because now we've brought on another 6 sites in this study. Yep, 6 sites into this study. So we found that diabetes was not a priority for some clinical sites. There was difficulties engaging and communicating with senior management. Senior management, if they were on board, had difficulty communicating with their nurses, and it didn't go as well as what we all intended. There was still big issues in the main trial still, even though everything we done, there were still issues around identifying, recruiting, and consenting. There was still that bias with staff. We had real issues around identifying educators and whether they have the capacity. And again, people with intellectual disability had transport issues and fixed routines of going to day centres or whatever. And then we also found out when people lived in supported living and residential, staff committed at the start, but when it actually came to the actually supporting the education programme for 9 weeks, some staff put people in the taxis with no staff support. When staff did come every week, it was a different staff member. And sometimes they weren't sent at all. We rang up and said, oh, we forgot. So there was real challenges there. So what we did retrospectively, so over the last number of months, we've been looking at trying to understand these barriers to recruitment and to why we failed to get from 450, we only got 265. And we thought, well, let's look at some implementation science theory. And I don't know if you've heard of CIFR, the Consolidated Framework for Implementation Research by Dram Schroeder. And we started to look at this and try to say, well, look at the paper we've published on QRI and then the main study. Let's see from all our reports and meetings, let's see if we can bring these barriers really up front. So the one thing I'm just going to show you is the intersection and then the inner setting. That's just, I could have done the rest, but just for time. So we used the inner settings of CIFR. And again, we looked at those problems that we found in the paper and the meetings. And you could see the ones in the yellow very clearly fell in the inner challenges. And we were amazed at that. And then we thought, right, okay, let's look at the sites and let's see who met, who had the challenges and who didn't. So as you can see here in the green, there was 5 clinical sites. All of these 5 on average they were meant to get 36, and that ranged between 29 and 40. In relation to readiness, organizational readiness, we found the staff to be very engaging. We had great buy-in from senior management. They had very clear networks between senior management and frontline staff. They had really, really strong connection with us. In fact, they invited us to team meetings. They went way beyond what we were asking, and they identified local champions. In fact, each of those 5 sites identified a learning disability nurse consultant who became a co-PI and baptism with fire with trials and stuff. And these sites were able to recruit 4 learning disability nurses, which we actually wanted 2 learning disability nurses and 2 diabetic nurses. But over the whole study, we never got 1 diabetic nurse. So we were happy with 4. But if you compared that with the other sites, there's one in the middle that's sort of a middle-ish. But if you looked at these other 6 sites, these 5 sites, some of these sites, sorry, I'll rephrase that. All of these sites were in cities with about 3,000 or 4,000 people with learning disabilities knowing the statutory services. And we know about 15% of people with learning disabilities probably have type 2 diabetes. So how did we struggle? And we retrospectively assess them as having low readiness. Again, we found discussions with senior management to be very ad hoc, and it wasn't very forthcoming, and it was a real challenge. And like you're saying, we had interviewed some of those staff, or we had some of those issues around where randomized controlled trials, they didn't see it worked, or diabetes wasn't a priority. They had no senior management in these sites had poor communication to nurses on the ground. And again, even to meet us, they were always cancelling meetings. They had not, we didn't really have one key person identified as a local champion who could fight on our behalf. They were always say, oh no, see this person, see this person. And again, so therefore they struggled to get a staff, and which was difficult because we needed 4 staff to run the education program. Now that's a lot. And just to say, the other thing was, curiously, was the 5 sites here were the 5 sites in Northern Ireland. Those other sites are in England and Scotland. So you have to ask yourself, what is it that's going on here that didn't happen across the water? And if you know the normalization process, that Carl May was one of the founders, he talks about trust and relationships and communication. And I've just, like I'm saying, lived in Northern Ireland all my life. I probably know most of the staff in Northern Ireland in this area, and we just had very, very strong relationships. And I think that was successful. Where I think across the water, they were struggling coming out of COVID. A lot of the teams, and remember, it was just out of coming COVID, this study, and a lot of the learning disability teams were still meeting by Zoom and Teams, and that probably wasn't conducive to relationships. So I think a lot of this is to do with relationships. So what can you do very quickly? We can look at some implementation strategies. I'll finish in the next slide or 2. Some implementation strategies. These are strategies. So in this case, this is to do with the inner setting, developing stakeholder relationships. These are our strategies that have been shown to work in other areas, and we can take them and we can apply them to our own trial. We can also, if there's some of these there, we can adapt them to suit people with learning disabilities or where we work, or we may have a new strategy as well. So a couple that we've used with a new site across the water, and I have to say, if we measure their readiness, they have been unbelievable. So we're looking for 100 people, and we asked for something like 12 nurses as educators. They said, no, we want to give you 20. They've actually have 4 healthcare assistants whose job it is to screen and identify potential people. And believe it or not, they're actually using GP surgeries. And they have got a list from every GP surgery of the people who meet our inclusion criterion. And they have the names already, even though we haven't got the funding and we haven't started yet, but they are ready. They are organizationally ready. And they're very committed to, on our behalf, going around all the charities, as they were saying, you wouldn't know them, so we'll contact them. So this is some of the strategies that you can use going forward and looking at implementing a randomized control trial in different clinics. I've only picked 3 here. We also found that in Northern Ireland, some of the educators who were really good champions for the study were actually visiting other sites to support them in delivering the education program. There's tons of these as well. I know I don't have time to go through. I'm going to stop there. I was going to do the pathway, but I'll not do that. I'll stop there and take some questions as I'm conscious of time.
Thanks so much, Laurence. So if you want to
this?
bring your screen down and then we'll be able to see everyone. Such
Yeah,
a fascinating effort, and I think people will have, it really resonates with some of the experiences we've had with some of our trials here. And it's interesting because we have folks doing implementation science work, but I know certainly for me, I've always thought of implementation science as something we apply to like putting things into healthcare as opposed to how it relates to research or research trials. So kind of seeing the steps that you've taken, I think is quite interesting. If people want to use the chat box or raise their virtual hands, maybe we can go ahead.
So I'll just say, so our clinical trials director, this is their first learning disability trial.
Right.
And he basically says, I have 3 comments upon your trial. Number 1, you can actually do a randomized control trial with people with learning disabilities. When you get to them, there's not a problem. When people say yes, if we get the people 95% consent, that doesn't happen in the general population. And also our dropout rate during the education program is far lower than the general population. And the feedback's good. Number 2, he said, your study was a complete failure on implementation science. Even though I hold this post, it's quite ironic. But that's because we never built no implementation science into the study. And I think that's something to think about. So one of the things of implementation science is right, do we assess sites for organizational readiness before we go out to them? How do you know a site is ready? And the third thing he says is, looking at your results and the Quintet study, is that the staff who are there to look after people with learning disability are doing a disservice to the people with learning disability, which is a damning the culture.
Yeah.
Because, and this is what I'm saying, I'm not blaming staff per se. I think it's to do with a broken system staff are in. So there's learnings, even though if we don't get the extra money and I hope we do, but because that site's so ready. But there are learnings from studies that don't work.
And just to say that recruiting 265 people to your trial is still quite something. So, and all the work you've done, I think, is so impressive. Do people have, I'm seeing a lot of nodders sort of resonating with your comments and what you just shared, Laurence, but do people have questions or comments for you?
If no one's going, then I'm going to go ahead.
Go ahead, Samia.
Can you hear me? Okay. Yeah. Hi, Laurence. It's really nice. It's very interesting for me to hear your presentation because of like multiple reasons. Like I'm working on a systematic review to understand, the barriers that autistic adults and like people with IDD, like they face towards joining RCT, and to hear your perspective as to like, like the barriers that they face is mostly coming from the gatekeepers and stuff was very fascinating. And it was also nice to like hear Peter's name over here because like I was reading his paper and then I get to hear it now, like small world. Um, in my previous work, I have worked on an implementation science study, but then that was not a randomized control trial. So approaching it from that lens would be very interesting, because we are also conducting a study in this center looking at an RCT evaluating antipsychotic induced weight gain in this population, and we're struggling with recruitment as well, I
Yeah.
think. So it was very inspiring to hear from you, and excited to delve deeper into some of the strategies that you shared, and to see how we can use that and learn from what you learned.
Yeah. So one of the things when my team were sitting meeting and we were thinking retrospectively around how, we failed to recruit, the numbers. And it was particularly these sites in England and Scotland that we were looking at, and then we thought, okay, well, this is our perspective. Let's go and ask the staff. And then, so we were retrospectively asking, were you organizationally ready? We actually think that they would have said yes, that they were ready. And so therefore we didn't want to get into a game of saying, well, we don't think you are, and you think we didn't want to get into that game. But going forward, so we have another feasibility RCT. It's to do with high intensity interval training in adolescents with intellectual disability and autism in special schools in Northern Ireland. And we got £100,000 from a charity. But the one thing we did in May was we actually gave out a questionnaire using the normalization process theory called NOMAD. I don't know if you've heard of it. We gave it out to 8 schools. And then that was in May. And then in June, we had a focus group with each school. So we had tried to get the principal, not all the time, but we got a couple of teachers, classroom assistants, and we asked them some questions around organizational readiness. Are they ready to implement, even though half of them are going to be not going to get it? But we were asking about their organizational readiness to engage in the trial and this intervention called HIT. So we're just analysing the results, and then what we intend to do is over the autumn then we're going to randomise 4 schools. If some of them weren't ready, it's what we do. This is the challenge now. What do you do? So let's just say you have 20 sites and 10 are ready. What do you do to the 10 sites that aren't ready? How do you get them ready before you randomise? So that's like a pre-implementation intervention before the main intervention. And then another question is that I have, how do you know the pre-implementation intervention actually works? Does it make a difference in the trial or not? But 3 big questions that we hope to put up for PhDs in the very short future. There's a couple of hands up, so I'll shut up.
All right, so how about Mickey and then Avra?
Hi, thank you so much for that presentation. It was really interesting. I've worked with RCTs and recruiting participants, and so it's really interesting to see from the IDD lens like how complicated it can be. I had 2 questions. I was wondering why did the GPs are less likely to kind of engage in this kind of work? Like, why do you think that was? And then also in terms of have you looked at when it comes to stratifying people with IDD from the general population and kind of what additional barriers might be involved in that?
So say the second part of the question again.
Because I was trying to clarify, so when you're doing the RCTs you've looked at, it's specifically you're looking at people with IDD. Are they being stratified from the general population?
Are they being
this is a trial specifically for an adapted intervention for folks who have intellectual disabilities.
Okay.
Yeah, so we just went to the learning disability teams and any learning statutory or voluntary learning disability organization.
I'm just going to interrupt for 1 second. So one thing you may not realize, Laurence, that we realize, and we may not realize what they have over on the other side of the pond, is we don't have learning disability teams.
Oh, okay, right.
So we don't have learning disability nurses, right? We don't have these regional local teams that are interprofessional that work in each community to give people support and care. So that's the team that you're talking about when you work with them for recruitment.
Yeah.
We don't have that structure, unfortunately, which makes it even more challenging, I think, here for us to be.
Yeah, and that's why we went to voluntary organisations. So we also we also spent £12,000. I pushed this. We also spent £12,000 on a social media campaign, and again, it was an absolute disaster. Because we were getting people who didn't have learning disabilities, who didn't have diabetes. We were getting people, because we were offering money, people were jumping on the bandwagon. We were also getting people who weren't in the clinical sites. We also had a mother from Wales, and we weren't including Wales, who just says, how did I get this? How did I get this message on social media? And her daughter was 8 years of age. Yes, did have a learning disability, but was 8 years of age. So she was quite irate. So I would not, although I know another study is doing using social media and is doing well. So the question of GPs, yeah, we just did one site. Half of them wouldn't get involved at all. The other, and we had a nurse going out to every single GP. The numbers would have been small. When you go to GP surgery, there's not a lot of people with learning disabilities, and then even less with type 2 diabetes. Just didn't. I don't know well. And they would have been getting £50 a head from the clinical research network, which is like a support network, but they didn't take up at all. I'm probably busy as well. And I would imagine it probably wasn't GPs. It was probably more the practice managers who you have to buy into.
Thank you.
All right, Avra and then Mavir.
Thanks. So I've just been nodding my head because I'm not specifically involved in clinical trials, but just in recruitment in general, everything that you're saying resonates tremendously, including struggling with GPs. And we are very jealous of your learning disability teams. They sound fantastic. I wish we had them. But the one piece that you mentioned that I was thinking about was the issue of how the recruiters are positioning the study. So both who they raise it to and then how they introduce the study. And I've seen very similar things happen here. There was one project that I was involved in where we were essentially recruiting people to fill out a survey. And we would hear back from some of the sites, people don't like it, they don't want to do it, they're saying no. And I would say like, okay, but I have some sites that have tremendously high participation and some sites have very low participation. So I hear you telling me, well, it's just because none of my clients like it. Well, like, is that the problem, or is it maybe something to do with how you are introducing it and how you're talking about it to them? And so I guess my question is, how do you address that? Like, is there a training you can offer, or how would you suggest that you coach or train or engage with the recruiters to support them to do better recruitment, essentially?
Yeah. So that's why in the Quintet study, we actually audio recorded that process, and we interviewed the recruiters and the clinical research nurses, and out of that then came we made a video for staff to try and explain the project. We also had the cue cards and the tip cards just to give them tips for how to sell the project as well. And the other thing that we did is particularly for the clinical research nurses. Now you must remember the clinical research nurses would not have experience of learning disability, and in Northern Ireland, this is the first ever randomized controlled trial in this population, and we found that they had apprehensions. So our research staff, who has experience of learning disability, they actually supported for about a couple of weeks. They went and they undertook the capacity assessments. They undertook the baseline measurements, and then they sort of shadowed the clinical research nurse, and then they sort of backed off after a couple of weeks. So there's a lot. It's quite intensive to get that sort of way people up to that skill set of where we are. And the other thing that we had then is on a monthly basis, we had a clinical nurse meeting the second Wednesday of every month. We brought the clinical nurses together from the 11 sites, and we just sat at the back and we allowed them to take control of the meeting, and they were basically bringing some of the challenges they had and then some of the solutions.
Great. Mavir?
Yeah, thanks, Laurence. Thank you. As Soumya mentioned, we have a study looking at intellectual disability, antipsychotic induced weight gain, and we are trying to study metformin in that context. We are supposed to recruit 90, but that's how the power calculation was done. We are at 10 at midpoint in the study.
Okay.
So we are really struggling. And so your thoughts are very welcome. I appreciate all that you have said. And of course, some of this is short-term fixes and some of them are longer term. But let's look at the practicalities of it within like the 2 years that we possibly have. what this low recruitment has, and I'm sure it happened at your end as well, ensured is that strangely you're over budgeted because you have made peace with the fact that you will recruit half or less of your sample. And then could that money, potential availability of that money, be used to, grease the appropriate wheels and lay down the appropriate resources to somehow help with any or all of these logistics? And if you were to do that, where do you think you would spend the money? What would be the most high yield ways of getting more out of the system?
So I think our sample was 450. We were never going to recruit it. So we agreed with the funder to go down to 350 at a p-value of 0.81. But so the study ended in October and we only hit 265. So we were still short in over 90 people. So this is why we've asked for a costed extension.
Right.
In the UK, the sort of the maximum costed extension is around about £250,000. So we're asking for another £250,000 to get that. So we're going to get near the 350. The biggest thing for me, if I was doing this again, is so the problem is when you come up with solutions, they're going to have a knock-on effect either for ethics and there are time, and that leads to money. So for us then, you see, it's about asking the question, if you're going to do a trial again with 10 sites, how can you ensure that they're ready to engage in your study? So there's two ways to do that. One is to build stage 1 into your study, which is before your internal pilot is assess readiness. Now, clinical trials unit may not like that because what you're basically they're saying is, well, you're manipulating the sites, but if you're just making sure everybody's ready, and like I'm saying, if half aren't ready, we have to do something to get them ready, and then you randomize. But that's extra money and that's extra time. Or what we're doing now is we're applying for a bridging for another study we're actually applying for £45,000 for a part-time researcher to, before we apply for the trial, to do some work around this organizational ready piece. So it's again, it just happens to be in schools and a walk-in intervention, but we're going to try and see what do we need to do to get schools ready here in Northern Ireland. But I think this is where implementation science really helps you to think about what are those barriers. So if you look at, you've 90 people, you've only got 10. My question would be is what happened to the other, I don't know how many sites you had, but what happened in those sites that you only recruited 10? To try and do some sort of, maybe you do that within your process evaluation, but during the process evaluation, you actually frame the questions maybe in CIFR or the normalization process theory, and that will help you to try and identify those barriers going forward. Hopefully that's answers your question.
Yeah, no, it does.
But I mean, like you're saying, 90 to get 10 is really disheartening. And then the problem is funders in the future will go, well, we're not going to fund you because you only got 10 people, you can't recruit. So I think you need to explain to the funder that, you need to do these trials, you need to explain why, but we need to do another little bit. It does cost a little bit more money and a bit more time, but we need to do that to ensure that we recruit.
Yeah, I agree. And I like Yona's idea of a grant to get people ready for clinical trials. Let's use the current grant to get ready. I mean, what else are we going to do? We try to recruit as much as we can, and let's use it to set up the infrastructure then. So that
have you done your process evaluation yet?
No. It's an ongoing.
Okay.
We obviously didn't have I didn't have the framework and the structure that you have, and so it's heartening to hear that you have put in that much work into it. So we can borrow from you. Thank you.
Yeah.
No, but we have done it in piecemeal fashion, like to see where we are low yield. So we also figured out that GPs are not going to be high yield. And so we are likely not going there. We are going to focus teams which hold more people with adults with intellectual disability. And there we are seeing all the process issues and the gatekeeper issues that you pointed out.
Yeah.
So all of that plays out in our study as well. Adding the antipsychotic piece just thins the cohort a bit more, like with you with adding the diabetes.
So I think the other thing as well is one of the things that we do all the time, and I have different staff, but we always offer a 20-minute online little introduction to the project. You know, we have a little video, the people with learning disability made this really, really good. It just tells this, and it's for senior management.
Yeah.
It's not, this is not for frontline staff. This is for senior management. Preferably, we would prefer to go out to where the teams are. Again, that's just to do with capacity, you know, and again, Canada's so big. But, you know, it's really about us getting out into meeting the senior management, eyeballing them, bringing down a box of buns, really them trusting us and having a good relationship. It's that buy-in. And that's the first thing about the implementation science, is about having that buy-in and making sure that then that they identify local champion who, when we're not there, is doing all the work on our behalf as well.
Yeah, thank you.
Okay.
I think you got us all fired up, Laurence. So fabulous. First speaker series talk for our calendar year. So thank you very much. I think you'll be hearing from several people from this group.
Yeah, I'll send that paper. We're just waiting on that paper. It's just going through the minor corrections. I'll send that paper on as well.
Thank you very much. And yeah, I hope this gets us all thinking, and also thinking about not only how we can collaborate with each other across the center. So some people are good at implementation science, some people are good at doing trial, you know, so we can work together, but also we can, you know, we can reach out to people like Laurence across the pond and think about ways we can also internationally kind of work on solving our problems. I was going to say that Katie McDonald, who you mentioned from the US study,
yes,
is going to be doing our speaker series in November.
Oh, very good. Oh, that's
I'm a bit obsessive about this issue right now. I don't at 90. It doesn't look good for us. And
I think it is a massive issue, and I think it's really trying to say to the funder, you know, trials are difficult, even more so in this population, but we need to think differently. But the problem is, if you think differently, there is going to be time and a cost to it.
Yeah.
And I think that's what you need to clearly articulate to the funder, why you're doing this.
Yeah.
You know, and hopefully then you will get the recruitment. But I mean, we were, so when we applied, worked with this new site in England, you know, we had like we've developed this organization already in our minds, that, you know, but we were asking specific questions, and they were like, yep, green, 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 green. I wish we had did it 3 years ago, because we probably would have been in the reds and the oranges for a lot of those sites across the water.
Yeah.
So I think it is important.
We know how to get letters of support from agencies. That's not very hard. But I think the trick is that we have to really make sure that people we're going to work with are ready and understand what it really means. So
yeah.
Yeah, and then Yanni's comment as well, keeping that equity perspective and ableist assumption, a really huge piece for us to.
That's it. And the bias thinking staff, everybody, like staff like this, like when we just sat down and asked this nurse, like, this is a nurse I knew, 10 people, but she only sent out the pack for 4. So we lost 60%. And if every nurse is doing that, you could just see how your sample is getting less and less. But people with learning disabilities are not being given the choice to take in trials. And when you do get to them, when we get to people, 95% go on consent, which is a far higher rate than the general population.
Yeah, I think working with some of our patient and family partners around why trials research matters, like how we're going to try to do it in a right, kind, and fair way, but also why it's a right to be able to do this kind of research. Okay, it's just after 1 on our side, so it's time for you to have your dinner and time for us to get back to work.
Thank you, and talk to you soon, Yona. Thanks, everybody.
So much, Laurence. See you, everyone.
Thank you.
Bye.
Bye-bye. Bye-bye. Bye-bye.